My pleasure to introduce you Professor Ghanouni. Stanford. He is the chief of the department in Stanford University. He has the, one of the first MR guided HIFU's center in US. He will explain to us his experience of this center. So thank you for your collaboration, and I really want to come and visit your center to see how it's working. Thank you for your talk.
Thank you for the introduction, Cyril. Can you hear me okay?
Yes, perfect.
Thank you very much for the opportunity to present. And I appreciate the audience's patience. So my name is Pejman Ghanouni. I'm a radiologist at Stanford. And I've been doing MR-guided interventions now for about 10 years or so. Today, I'll be talking a little bit about the integration of focused ultrasound, but of MR-guided procedures into routine patient care here at Stanford. And I've titled this Unique, Complementary, or Competitive Solutions. So I'll try to explain a bit about what I mean about these things. These are my disclosures. I receive research funding from Insight Tech. I work with them on their prostate cancer application. I'm also on the scientific advisory board of Sense. So over the past 10 years, our service at Stanford has grown from something that was basically me wearing a lot of hats to the team that you see here. We've built something that we call MIMRIC, which is the Minimally Invasive MR Interventional Center. This is like an interventional radiology service, but with a concentration in using MR guidance for the various interventions that we do. The premise behind this is that it's the MR component as much as the interventional component that needs expertise. And so my colleagues here, Dr. Brunsing, Dr. Sates, Dr. Loning, are all specialists, radiologists and specialists trained in MR imaging specifically. And then this is the team that's been supporting us within nursing, physics, our PAs and MAs and nurse coordinators, our nursing staff, and our MR technologists. This team currently works on biopsy of lesions seen only on MR-guided focused ultrasound interventions, and MR-guided cryoablation. So it's a group without which I wouldn't be able to talk about much of what I'm doing. The vision that we have is a concept of kind of changing our service line, where the concept is that we take a diagnostic MR that leads to identification of an abnormality. We then go to MR-guided tissue biopsy for pathologic diagnosis, and then MR-guided therapeutic intervention. So the focus is on MR. The current applications that we use MR-guided focused ultrasound for within MIMRIC include the treatment of bone metastases, soft tissue tumors, essential tremor, and other neurosurgical applications, uterine fibroids, and prostate cancer. So all of these are in active use and in common use here at Stanford using focused ultrasound. As far as some themes for the talk and trying to think about the keys to the integration of focused ultrasound within our research group and taking it from a research group to a clinical utility. One, you'll see that I'll be talking about using focused ultrasound to target an unmet need. Neil was asked a question about what can ultrasound not do, and I think his answer was, first we have to think about where are their unmet needs. Everything we've done has been built collaboratively through research. This technology is housed within radiology, but as you'll see, every one of these applications involves collaborations across disciplines. And the strategy that I've taken is one that I learned from a visitor who once came to learn about treating desmoid tumors and bone tumors with focused ultrasound. I think I learned more from him perhaps than he learned from me. And he gave an example about how at his institution he does cryoablation for renal tumors. And he learned the hard way, he said, to split things with his urologists. And even though on the treatment day, the cryoablation day, the urologist may not do much other than to confirm that the needle is inside the renal tumor, which the radiologist knew already. He said, if it's 50-50, everybody's there and happy and the concentration is on the patient. But the instant it becomes 51-49 or something other than 50-50, then people lose interest and the referrals go away. So I've really taken that to heart. And as he said, I'd rather have some of something rather than all of nothing. And the concept is that we've tried to build our solutions in a way that makes it a win for everyone. And hopefully you'll see what I mean. As an example of one of these applications in using the concept of targeting unmet need, I used prostate cancer. Obviously, prostate cancer is common. 1 in 9 men are going to develop prostate cancer in the United States. This past year, close to 200,000 men developed prostate cancer. Of those, about 75% have localized disease, so we're about 140,000 or so. And if we estimate about a quarter of those have intermediate risk disease, that's 35,000 men that could be candidates for a focal therapy. The other point to make in terms of an unmet need, what I really mean by that is that current approaches to treatment are not optimal. So if you take a man and put him into surveillance, which is an option for low risk disease, as well as maybe some good intermediate risk disease, you can put men into surveillance. And what's been shown, though, is that many of these men progress from active surveillance. So if you split these men that have early stage prostate cancer and put some of them into surveillance versus giving them radical therapy up front, you'll see that maybe about half of them within 5 to 10 years end up getting some kind of therapy. So the surveillance works for some, but for many just delays the care. Standard treatments often require reintervention. So after a radiation, there's about a 30% recurrence rate. After a radical prostatectomy, there may be about 1 in 5 men that need further treatment due to rising or persistent PSA. And these current therapies suffer from high morbidity. So if you look at the 5-year cumulative incidence of needing a urological procedure, of needing a rectal or anal procedure after radiation or radical prostatectomy, you see that these numbers are high. If you look at this graph here and you look at, for example, after nerve-sparing radical prostatectomy, what percent of these men have good sexual function? You know, we're less than half. If you look at the impact on urinary continence, you can see that there's significant drops to 50 to 60% of men have issues with urinary dysfunction after these treatments. So I would say that there's an unmet need and that the current methods are not optimal. Bring in MR. Obviously, as we know, over the past 10 to 20 years, MR has become more and more utilized for identification of the index lesion in the prostate. And this requires multiparametric MR using T2, diffusion-weighted images, as well as dynamic post-contrast images. These don't identify all the cancers in the gland, and we've learned that we don't want to identify all the cancers. These low-risk cancers are probably clinically irrelevant for most men, but what we want to find is the most worrisome-looking cancer, with the idea that we can then help the urologist or the radiologist guide biopsy of this lesion. If this is the index lesion, if this is the most aggressive lesion within the prostate, then it should drive management. And these are examples of us using MR guidance to now target that specific lesion within the prostate and identify what kind of cancer it is. And what we end up with is this population of men, as I mentioned, that have intermediate risk prostate cancer. This is a locally confined disease. It's Gleason 3+4 or 4+3. These are men that I showed you within active surveillance. Many of them are going to progress, and they have this burden of knowing that they have a disease that they're monitoring, which many men find uncomfortable. Many men and their families find uncomfortable. On the other hand, it's not high-risk disease, so giving them whole gland therapy, prostatectomy, radiation, whole gland ablations leads to disadvantages of incontinence, impotence, and other toxicities, leads to overtreatment. And so for these men with intermediate risk locally confined disease that's identified on MR, we'd like to use MR guidance to drive therapy and find a solution for focal therapy for these men. And this is an example of this. This is a man that has this very obvious lesion on T2 and ADC and post-contrast imaging. And you can see what we've done here. This is using the InsightTech transrectal system here as part of a clinical trial. And we basically contoured the prostate. We've told which portion of the prostate we want to be able to target. So it's not only the tumor, but a margin around the tumor. The system lays down a bunch of sonication foci. And then you can see here the thermometry as we go through and ablate that portion of the prostate, and carefully monitoring not just the ablation zone, but also the rectum and the tissue around it. And you can see immediately afterwards, I can tell that I've successfully ablated that portion of the prostate. So we've done this as part of a clinical trial, And we also do this with prostate MR-guided cryoablation for some men. So these are cryo needles that have been placed. We use this typically for anterior tumors where a transrectal approach might be a problem. We've adopted this approach, and that's worked quite well. And more recently, we've introduced the transurethral system made by Profound as a method. This is a summary of the results of their clinical trial that led to FDA approval for this technology for treating prostate tissue. As many of you know, this is a transurethral device. It rapidly sweeps through the prostate. For the clinical trial, this was whole gland therapy, but obviously it can be used for focal therapy as well. And within about half an hour, one can ablate the whole prostate. So it's an efficient system as well. And you can see in their trial, of the 68 men that had this intermediate risk disease, 79% were free of intermediate or worse disease at 12 months. And in terms of side effects, 90% plus maintained urinary continence. 3/4 of the men maintained erectile function, and this is after a whole gland therapy. So one would expect even better function after partial therapy, which is what we're starting to use this for too. So again, this is a summary of that vision. The MR led to the identification of a index lesion. We biopsied it under MR and treated it under MR guidance. This is the vision of our MR guided procedures program. Now, we have built this program through collaborations, through research. This is one example of this, in which years ago we started a clinical trial for the treatment of sarcomas. And the concept behind it was that if we were ever going to use focused ultrasound to treat soft tissue tumors, malignant soft tissue tumors, we would have to be absolutely confident that when the MRI said that a lesion was, that an area or that the tumor was killed, that it was ablated, that the histology supported that. And so we took a number of men and treated them, men with biopsy-proven sarcoma who were going to go on to standard of care surgery. We took them and treated them, here you can see before focused ultrasound and immediately afterwards, and we specifically ablated only a portion of these tumors and then sent them on to resection. And the point I'm making here is that this is all research, and this is another example of this rising tide. We're an academic institution. The part of the currency of this institution, of course, is research publications, research dollars, getting grants, and so forth. And so this kind of collaboration is something that benefits the academic careers of all of the folks involved. And these are just some of the publications that came out of this work. You can see what we've done here. We've taken this tumor, and now we've done a slice-by-slice comparison with the pathologist, looking at where does the imaging say it's dead versus where does the pathologist say it's dead. How well does this correlate? And these are the men that we treated here, and looking at some of the technical parameters behind that. So this is an example of using research to drive the development of therapy. What do I mean by that? What I mean is that actually during that study, we realized, look, there's a number of challenges to doing these kinds of treatment with the current embodiment of the focused ultrasound system. Number one, the tumors that I showed you are very close to the skin, and the absence of active cooling was going to limit our ability to treat these tumors without causing skin burns. On the other hand, and the other challenge, of course, is that it was going to be a long haul to change the approaches of surgeons and oncologists to treating sarcomas. On the other hand, our surgeons and oncologists came to us and said, look, we have this other tumor, a desmoid tumor. It's a fibrous tumor. We know that focused ultrasound works well in fibrous type tissue, for example, the T2 hypointense fibroids. These are tumors for which current treatments don't work well. These are not malignant tumors. They're not going to metastasize, so there isn't the same need to be aggressive with these tumors. But on the other hand, if left alone, they're locally aggressive and cause a lot of side effects. So working in collaboration with our orthopedic and medical and radiation oncologists, we began a multidisciplinary effort to treat desmoid tumors. This is an example of the challenges that were faced with, at that time, standard therapy. You can see that this tumor in this young man's thigh is very close to the sciatic nerve, close to muscles. In an effort to cut out this tumor with a margin, you can imagine that you're putting all of these other structures at risk. These are examples from the surgery, and an excellent surgeon, clean results on imaging, clean result on surgically by vision, clean result pathologically. This was an R0 resection. There was no evidence of infiltration of the desmoid to the margin. Unfortunately, as is far too common after surgeries for desmoid tumors, there was a local recurrence within a few months. So the patient went through a very morbid procedure, a risky procedure that thankfully did not involve injury to the sciatic nerve, but did cause some loss of muscle, and despite that, afterwards still had local recurrence. So we felt like, look, we can definitely do better than this. Obviously, radiation is an option. It works in about 70 to 80% of these patients, but carries significant morbidities in about a third. The worst side effect is that the patients develop about a 5% lifetime risk of developing an actual cancer. So for a young person in which radiation seems not to work as well anyway, for desmoid tumors, to give them to develop a risk for actually developing a sarcoma later seemed too much. And also a variety of chemotherapies have been tried, systemic therapies, targeted therapies as well. None of them work that well. At best, maybe 70 to 80% results with significant toxicities. So there was clearly a clinical need. So again, targeting an unmet need, working collaboratively with our colleagues, first in a research environment. We developed methods to adapt the in-table MR-guided ultrasound system that was designed for treating women's uterine fibroids to now treating tumors all over the body. This is an example of someone that had a large desmoid arising above the apex of the lung into the subclavicular and supraclavicular spaces here. You can see on the coronal, sagittal, and axial images, it's a large tumor that was growing and infiltrating. And you can see here what we did is this is our effort to figure out a way to position this patient. We learned over time how to treatment plan, how to modify sonications that were optimized for fibroids and change them into sonications that were optimized for desmoids. And this is a tumor that's very close to the brachial plexus, very close to other structures. Our goal with these patients, because this is not a cancer, is to control the tumor. And you can see that we purposefully left a rind of tumor behind. These are patients that we treat. We kill a lot of the tumor shrinks, their symptoms get better, we bring them back and treat again as needed. So far, we've treated now more than 60 patients with focused ultrasound, another 40 with MR-guided cryo. And of these patients, the location of the tumors all over the place, many of them in the torso, but upper and lower extremities, the shoulders are very common. Patients as young as 4 and as old as 66 years old. And we've been following these patients now for, on average, about a year or so, but up to 5 years in some cases. We hit home runs just often enough, I say, to keep this, keep going with this. These are long procedures, many hours of treatment. You're kind of nibbling away, burn after burn, sonication after sonication at these tumors. If I were going to design a technology from scratch, I would redesign the technology that we have if I was trying to target desmoid tumors. But because as you can see, for the smaller tumors, it might take an hour, but for the larger tumors, I've had patients that we were sonicating for 8 hours. It's a very slow process, and it has a lot to do with the proximity to skin and to other critical structures. As I said, we kill about 60% or so, more than half of the tumor, and these tumors shrink and in size, and patients are, you can see also by a RECIST as well, the amount of viable tumor shrinks as well, of course. And these patients benefit. Their pain scores go down, their quality of life goes up. And this is with a non-invasive incisionless surgery, where even though we're on average not killing most of the tumor, well, we're killing the majority of the tumor, but we're leaving a chunk of tumor behind, we still see clinically significant effects. Patients are able to come off of their chemotherapies, avoid those side effects, avoid the morbidity of surgery and radiation, and get focused ultrasound. So although most of the time we're not treating all of the tumors, we do have, as I said, some wonderful stories. This is a young man that was actually featured in a recent Focus Ultrasound Foundation newsletter. He had a desmoid tumor growing out of the palm of his hand, very close to the tendons and nerves on the ulnar side. And you can see this is our ablation after the treatment. And you can see 12 months later on imaging, there's no residual tumor. And you can see a photo of his hand. This is a made-for-TV movie. He's now a pre-medical student at Stanford. So the kind of full circle. I hope one of these days he becomes a radiologist and starts offering focus ultrasound to patients, but he's really experienced this all the way through, from somebody who, as a high school student, had to stop doing his lacrosse and other physical activities because of this tumor. He eventually became an all-American lacrosse player and has done really well. So as I said, many of the patients we're not able to treat all the tumor, but we have these tremendous successes often enough to keep going. And even in the patients where we're incompletely treating them, they clinically benefit. Our experience and the experience of others, and in particular, I should mention Dr. Andrew de Bratwer in Melbourne in Australia, who really pioneered this experience and shared a lot of his knowledge with us. But now it's grown beyond that at UCSF, in Wisconsin, in Italy, in DC, in Switzerland. The team at Mayo here shared some images treating a retropectoral desmoid tumor. The team at Utrecht using the Sonolive system treating an abdominal wall tumor. And I should mention as an aside, many of you may know this already, but this device recently got a CE mark for treating desmoid tumors as well. So this, as we built our experience, you can see that there's increased adoption of this technology. And in the United States in particular, one of the things that's made a big difference is that through our effort and the efforts of our colleagues in oncology, because it's a team effort, we were able to go to our oncologists and ask them to change their guidelines. And so now you can see that for desmoid tumors, our NCCN guidelines say surgery or ablation or radiation or chemotherapy. All of these are considered first-line options for desmoid tumors. This makes our work much easier when I go to an insurance company and ask for authorization for this procedure. When they look at the guidelines that they refer to, they now can see that at least among oncologists, it's considered appropriate for ablation to be considered a primary option. So this is an example of kind of the heavy lifting that Neil was talking about as well. Everyone has to work together to drive this technology forward. It's not just the vendors, it's not just the physicists and the clinicians, but we have to get to the point where we're changing the system itself to allow adoption of this technology. And it's been a slow process, but a slow win, I would say. Changing gears to another example of a collaborative approach. There's MR-guided focused ultrasound in the brain. And as you saw, we offer this for central tremor, and I'll talk about other applications. These are all the colleagues, most of the colleagues, I couldn't fit them all on the screen, that I work with within neurosurgery, within radiation oncology, and the clinical team and clinical trials team that have led to our successful introduction of this technology at Stanford. These are examples of one of our patients, and you can see the beauty of this approach where in real time, sonication after sonication, you can see the immediate effects of this treatment. Somebody who basically their handwriting was illegible, and an hour later, 2 hours later, now their handwriting's better than mine, and they're able to draw straight lines and so forth. And it's a very gratifying approach, and the immediate feedback is wonderful. This is something, again, that began from research. This is Elias's paper, published in New England Journal. This was a multi-center study that grew out of his early phase study, and many of us are familiar with it, obviously, a sham-controlled study showing that there was significant improvement in hand scores and tremor scores and overall scores and quality of life scores. We published on the 3-year follow-up of this cohort as well, showing that these results were durable, again, about a 50 to 60% durable improvement in tremor scores and quality of life scores at 3 years. So this benefit remained significant even when we accounted for some of the patients that were missing from the study. So again, this was research driven, and thanks to that research, Stanford had a first mover advantage. So you can imagine at the beginning, we had to go to our hospital and say to the administration and the MBAs, the accountants, and say, we want you to invest several $1 million and the time of a neurosurgeon, a radiologist, nursing staff, technologist, an MR suite in a technology that is not yet FDA approved. Somehow we were able to do that. They had the vision to do that. As a result, we now have what I call a first mover advantage. What do I mean by that? We have experience. We know how to do this. And now that it's FDA approved and has been for years now, we have a clinical service that builds on that research experience and that collaboration between neurosurgery and radiology. We now have learned how to improve our targeting within the thalamus so that we can more precisely target the VIM in a patient-specific way. We've learned how to account for these different skull types and figure out how our spot shape is going to be affected by the skull scores, by the angles of the incidentating beam, by the power that's being delivered and which elements are being utilized. We can now do a better job of spot shaping based on this, and it's all experience-based. And so this is an example of focused ultrasound as a complementary tool. So on the one side, I can say, here's an example of our of a little media thing that we did with our 100th patient. So because we invested in this back in 2013, in 2021, we can say, you know, we are one of the busiest sites. We have some of the largest experience in the United States in treating these patients. And that obviously resonates with patients to know that the doctors they're working with are ones that know what they're doing. Before, when I was talking about desmoid tumors, that was an example of a unique solution, right? In that context, the surgeons didn't like the surgical results. The radiation oncologist didn't like the results from radiation and the risks from radiation. The medical oncologist didn't like the results from the chemotherapy they were giving and the side effects. So focused ultrasound for desmoids was a unique solution that was being offered. And so it was sought out by the oncologists for that capability. Here, focused ultrasound is a complementary tool. It complements deep brain stimulation. And so for some patients, DBS is appropriate. In other patients, focused ultrasound is appropriate. And what we've done in terms of making this a win for everybody, you can see that after focused ultrasound became FDA approved, actually the number of cases of DBS treatment for essential tremor went up. So our neurosurgeons became busier doing what they like to do and what they are expert in, DBS, deep brain stimulation, even though we offered an alternative treatment. Why is that? Patients came to ask the neurosurgeons about focused ultrasound. Some of them weren't good candidates because of their skull. Some of them had such severe bilateral tremor or vocal tremor or head or a tremor elsewhere in their body that DBS made sense. And in other patients, because of their skull and because they were poor surgical candidates, we sent them on to radiation therapy with CyberKnife. And so this became something that was a win for all the different departments working together to the benefit of our patients. So this is an example of focused ultrasound as a complementary tool. This is another example. This is one that I already mentioned, but another example of FUS as a complementary tool. So I've mentioned, you know, the idea of targeting an unmet need. I've mentioned the idea of building things through research. But I think the other win is when the focused ultrasound either is unique or complementary. And so here you can see, what do I mean by that? Well, focal prostate cancer therapy, as I mentioned, is becoming more and more of a reality. We started off with a clinical trial using focused ultrasound, as I showed you, to treat patients with Gleason 7 intermediate risk prostate cancer. That trial closed, but men kept on coming to my colleague in urology, Dr. San, interested in focal therapy. And in the interval between the closure of that trial and being able to offer MR-guided focused ultrasound, Dr. San got a Sonoblate system and was able to offer transrectal ultrasound-guided HIFU as well. We also built MR-guided cryoablation for the men for whom, as I mentioned, transrectal treatment wasn't a good approach, either because of the size of the prostate or intervening calcifications, for example. And so we built services out of these other focal therapy approaches. It was good for Dr. San, it was good for radiology and urology together. Again, a benefit to both groups. And then more recently, Dr. San and I have worked together to now introduce the TULSA system, the transurethral system for our patients. And this is an example of one of our first patients in which a PSMA PET scan showed recurrence. This is recurrence after radiation. And so we were able to do a whole gland treatment very quickly, as you can see, after we identified this recurrence. And this is, again, something that's done very collaboratively. Dr. San is present, I'm present, and we've also, when I say 50-50, it's not just 50-50 academically, but the two departments work together, the revenues are split. It's something that works well for everybody. And the focus is on what can we do that's optimized for the patient. Is cryo the best thing for the patient? Is a Sonoblate treatment, an ultrasound-guided HIFU the best? Is a transurethral approach the best? We try to optimize things based on the type of cancer the patient has, whether we want to do whole gland or partial gland treatment. What about intervening calcifications? What is their erectile function? What is their urinary function? All of these things add together, and our concentration is not on, well, he does Sonoblate and I do TULSA. The concentration is on which of these therapies is best for the patient. It sounds obvious, but it really works well. It's easy to realize this when it's a collaborative approach between the surgeons and the radiologists working together on this. So it's another example of FUS as a complementary tool. My experience with this as a complementary tool came actually from fibroids, which is, you know, the original application of MR-guided FUS, at least with the Exablate system. Years ago, we talked among the interventional radiologists and I, and then finally with the gynecologists as well. And we realized that even when it comes to uterine fibroid embolization, which was a more established approach for treatment of uterine fibroids, there was very little crosstalk between gynecology and interventional radiology. Why is that? Well, surgeons are paid to operate. They're not paid to refer a patient to interventional radiologists. And so even in an academic institution, and certainly in a community setting, there is a disincentive to referring for other treatments. And so as a result, my colleague, Dr. Sepin, who came from another institution where he had a large cohort of patients that he had treated with uterine fibroid embolization, did a lot of community outreach, did a lot of outreach within the Stanford network, and very little referrals occurred within this population that he had. And we wanted to somehow get around that. So what did we do? We set up this service that's the Stanford Fibroid Center. It's a very laborious service, and by that I mean it requires a gynecologist, interventional radiologist, and an MR radiologist working together to see patients. And so one patient can take an hour of time from 20 minutes, 30 minutes, sometimes an hour of each of our times to see. At the end of that time, that patient leaves, that woman leaves knowing really why do we recommend surgery for her? Why do we recommend embolization for her? Why do we recommend focused ultrasound for her? Or why do we not recommend those things? Many women came in asking for MR-guided focused ultrasound because it was the least interventional, the least invasive option available to them. They didn't want little particles injected into them. They didn't want to have a big surgery done. And what this became a perfect example where we turned something that was that looked like a competition, whether it was a competition with embolization or a competition with focused ultrasound, we changed it into something that was complementary. We made it so that, again, we eliminated any of the financial disincentives. It didn't matter what kind of procedure the patient had. All the money went into a pot, and we let the financial people in gynecology and radiology figure out how to divide that money up. It didn't matter to us. And what mattered to us is that these patients got the best care available to them. And the patients also were on board with all of this, of course. And what did we see as an outcome from that? And again, this is a great example of a rising tide lifting all boats. Academically, publications. Clinically, an oversubscribed service that barely can keep up with the demand from patients. We are scheduling patients routinely 6 months ahead of time, trying to get into our service. From a radiology perspective, you can see that since the opening of the service, the volume of MR for diagnostic purposes has tripled. So from a financial perspective as well, this has been a boon to the radiology department. This also goes into that same pot. Gynecology benefits from this too, because it's a direct outcome of that collaboration. And as you can see from their side as well, this is a quote from one of my close friends and colleagues in gynecology that I've been working with for years in building this service. She's in clinic 2 days a week, but about half of her surgeries come from her half day at the fibroid center. What does that mean? That means in the half day that she's seeing, we can maybe squeeze in 6 to 8 patients, given how time consuming it is to see these patients. Many of these patients go on to get surgery. Why is that? Because they come in and maybe they're dead set on getting focused ultrasound, but when they learn, they're not good candidates for FUS, and then they get to talk to a surgeon who is doing surgeries through a tiny laparoscopic incision. It's not an open hysterectomy like maybe the patient's mother had. It's a tiny laparoscopic surgery from which she recovers in a few weeks. It's a win for everybody. The patient gets a great result, and overall the services grow. This is the essence of this, what I describe as a change from a competitive to a complementary tool. And so this was a kind of not just for FUS, but also for UFE, for fibroid embolization. We changed the perspective of the urologists. We had them buy into diagnostic MR and the value of that, but also into the value of this collaboration with radiology. Now, here is an area where that competition still exists, and I'm still struggling at times to change this, for this particular application, to change from competitive to complementary. Bone metastases are an ideal target for focused ultrasound. Rather than struggling to get through the skull, you're actually targeting the bone here, for example, right? And as we know, bone's a very efficient absorber of ultrasound energy. There's ample evidence that shows from a randomized controlled trial that about 2/3 of patients respond to this focused ultrasound therapy. Patients with metastatic bone cancer that has not responded to radiation, that's poorly controlled by medical options, responds really well to focused ultrasound. And these are images from a treatment in the right pelvis. And as we've shown recently, if you look at patients in particular that were treated technically adequately, they had what I call the black band, they were treated with high energy density on the bone surface, those patients responded. And so really the response rate isn't just 2/3, it was closer to 89 to 90% of these patients responded to this treatment. So we have a technically wonderful treatment. It works really well, and there's definitely a patient population for this care. What do I mean by that? I mean that there's a lot of patients with metastatic bone cancer, and we know that radiation works, but its durability isn't great, and it doesn't work for everybody. Easily, for 50% of patients, it works well, 60% perhaps, but that leaves a large number of patients where radiation hasn't worked well. So why hasn't focused ultrasound been adopted? There's clearly an unmet need. Technically, it works well. We have randomized controlled data. Well, some of this is just a lack of familiarity between the medical and radiation oncologist. The medical oncologist sees the patient complains of bone pain for years. The medical oncologist has a reflex to refer to the radiation oncologist. We have to break that reflex. We have to get into that process where they think, oh, what about focused ultrasound? But it's also, there's an opportunity cost. We need an MR scanner for this. That scanner could be doing diagnostic MRs of shoulders and knees and heads. And so, we're going to take up that scanner for hours. That has to be accounted for. And of course, as opposed to radiation, especially now where radiation is more commonly done in a single dose as opposed to multifractionated, we have the additional need for anesthesia. And so that perception, that's also a challenge in terms of wider adoption. Some of what's also missing are comparative studies. And there have been case cohort studies, I refer you to this study from Lee et al., in which they compared radiation to focused ultrasound, not directly, but in a case cohort study. They also saw something that was seen earlier, which is that focused ultrasound patients respond very quickly to this treatment. And within a week or so, patients are recovered and have improvement in pain after focused ultrasound. Eventually, the radiation patients reach there as well, but it takes perhaps a month or two to get to that same treatment rate, that same response rate. Well, what has been done? In Europe, I commend the team that's working on further. This is a study in which they're directly randomizing patients to receive radiation or focused ultrasound, or in that case, combined radiotherapy. Working with the team that's piloting further in Europe, we are introducing what I would call a mini further at Stanford, where we will be randomizing patients to radiotherapy versus focused ultrasound. I'm working closely with a colleague in radiation oncology, Dr. Vitsum, who he and I will see these patients together and randomize them 1-to-1 to get either focused ultrasound or radiation and generate direct comparative data between these two. That's hopefully going to take this focused ultrasound. One, I think it will validate the results that we see here in these other kinds of these case control studies in which we see that focused ultrasound works quickly compared to radiation. I think what I would like to do ultimately is, again, to take this from a treatment that is seen as competitive with radiation and see it as complementary. It's possible that you could treat a patient with focused ultrasound and with radiation, and you could get the benefit of getting quick pain relief from focused ultrasound treatment, and you could get the benefit of tumor kill, of tumor control from the radiation. Remember that with focused ultrasound, we're palliating most of the time. We're not doing tumor control, whereas with radiation, they're getting palliation through tumor control. And so we can combine the best of both worlds, early pain relief with focused ultrasound, tumor control with radiation. So for now, we're doing our randomized study, but ultimately, I hope to change this into something that is seen as complementary and not competitive, working again closely in a multidisciplinary fashion. There are a number of other applications that are growing out of this. So because we have MIMRIC, we're able to take focused ultrasound from bone metastases and explore it for osteoid osteomas. There's a clinical trial that Dr. Buckner at UCSF is piloting that we're collaborating in, where we're randomizing patients to CT-guided RFA or focused ultrasound. Here it's focused ultrasound versus radiation. We've taken focused ultrasound for desmoid tumors, expanded to treating metastases and desmoids, not just with FUS, but also with cryo. And now that's led to combination studies with cryo and drugs, where we're trying to find kind of a two-pronged approach. For essential tremor and neurosurgical applications, we've now opened clinical trials. I've treated patients with hippocampal epilepsy with focused ultrasound recently. We will open a study to, we've done pallidotomy for Parkinson's disease. We're going to open a study to do patellothalamic tractotomy soon. And we've also opened a study, these are Inside Tech funded studies, to do bilateral thalamotomy for essential tremor for patients that have bilateral tremor. And so all of our effort at establishing MIMRIC now allows us to expand to these other clinical trial applications. Again, unmet need, research, eventually to clinical adoption. A final example, going from fibroids in our experience treating fibroids and treating desmoids, and now we've recently opened the study to treat pancreatic cancer. This is an example from the first patient that we treated. Our goal here is not to ablate all the cancer. We're never going to be able to do that. It's too infiltrative. It's too close to everything else. But our hope is that we can, as Neil mentioned, excite this cancer, excite inflammation here in a way that allows immunotherapy to act on this cancer in a way that immunotherapy by itself has proven to not work well for pancreatic cancer. This has led to a number of engineering efforts as well. We're going to introduce acoustically transparent coils that we can shoot through directly, so improved imaging, but also allow us to that will allow us to visualize these pancreatic targets, but also allow us to insufflate directly through the coil. And we've also, because of some of the side effects of our desmoid treatments where we've resulted in skin blisters and sometimes worse, we've introduced a cooling system made by Allison Payne at the University of Utah to help treat our patients and help increase the safety of this study. So in conclusion, I've shown you a number of applications for brain, for bone, for soft tissue, for prostate. And hopefully I've left you with the idea that this is truly a multidisciplinary team effort. It's something that we've worked together on closely. We've targeted an unmet need in every one of these approaches. We have used research to drive clinical adoption and to build the clinical team as we transition from something that's done for a clinical trial to something that's done routinely for patient care. And hopefully I've also left with the idea that focused ultrasound is best when it's a unique solution to a problem or when it's complementary in a way that allows everyone to participate in the improvement in patient care. Thanks very much for your attention. I appreciate your time.
Thank you for your presentation. Maybe there is some question from the audience. Yes.
Thank you for the presentation. It was very interesting. You were speaking about cooperation between surgeon and radiologists in the interest of the patients. Don't you believe that in the future you will have to face a kind of competition? Radiologists using MRI guidance for focused ultrasound and the opposite surgeon using ultrasound guidance.
The competition you're describing is one in which radiologists are doing MR-guided treatments and surgeons are doing ultrasound-guided treatments?
Correct, yes.
Yeah, we actually have this quote-unquote competition currently at Stanford. Our urologist offers ultrasound-guided focus ultrasound, transrectal, and we offer this transurethral MR-guided ultrasound approach as well for treatment. We've tried to make this as a win for everyone. What do I mean by that? I mean that when the urologist refers a patient to us for the MR-guided approach, I share the revenues from this. Our departments share the revenues with this 50-50 with him. So we make it so that we eliminate any disincentive. And I don't mean this about this urologist personally. I mean that, you know, we all have to get past these financial incentives and disincentives. And what I'm trying to do is to set up a structure in which all of that is gone. And instead, we are just looking and saying, okay, we're going to use this approach because there's calcifications between the rectum and the tumor. So obviously, we don't want to do a transrectal approach. Why even bother? We'd rather use a transurethral approach. Or we'd like to do MR-guided cryoablation and get past the calcifications. Or the prostate is too big, or we want to use an approach that has MRI because we believe MRI allows us to visualize the tumor and because we believe in thermometry. I'll tell you this, one of the main advantages of working closely with my urologist is he has seen over and over again how heterogeneously the prostate tissue responds to heating. And when that happens, he can see that some portions of the prostate at a given energy reach very high temperatures. Other portions you have to heat over and over again in order to get to thermal dose. He doesn't have this benefit when he's using an ultrasound guided HIFU system, right? He doesn't know what's reaching thermal dose and what isn't. Because he has that experience of working with us, he's bought in. He realizes the value of MR guidance. And that experience, coupled with the elimination of any financial disincentives, it's proven a win for everybody.
Okay. I have a question, Gilles Dubernard. You know, in France, there is a limitation for the development of MR-guided HIFU treatment in gynecology. There's only one center in France which is located in Bordeaux. And the limitation is due to the cost of the device and also the duration of the procedure. What do you think about the combination of devices which combine MRI, fusion between MRI and ultrasound for the treatment? What do you think about this type of device? Do you have the experience, and what do you think about that?
I think your point is a good one, which is your main point is that the MR system is cumbersome. It requires an MRI and it's slow. So in particular for fibroids, for example, at least the version that we have is a slow version. Even the other approved version approved in Europe is not super fast for large fibroids. So, you know, could we, if we started today, would we design a different type of system? Would we design something, for example, that operated at low frequency plus at maybe a harmonic? You know, that's how the Tulsa system operates, right? It operates at 2 different frequencies. And so you can do larger burns and then also smaller burns. You can imagine doing this approach for fibroids as well. I think ultimately for fibroids, you will end up with an ultrasound guided HIFU system for that, just because of the reality of things. I think that the way, at least in the United States, things are set up, gynecologists see the patients in their clinic, and if they could treat the patient in their clinic, that would be ideal. So if there was an ultrasound guided HIFU system that allowed them to treat the patients quickly in their clinic, I think that that would be rapidly adopted. You know, the added value of MR in that context, I guess, would be for safety and for thermometry, perhaps. But as we know, many of these ultrasound guided systems work very well without necessarily all the bells and whistles of thermometry. I don't know if you necessarily need to add both. We were going to do a study actually with a company that unfortunately went out of business, but we were going to do a study where we were going to do an ultrasound guided focus ultrasound fibroid treatment and then just do an MRI before and after. And the idea was to use the MR to figure out the treatment parameters necessary to result in complete fibroid treatment. But at the end of the day, if that device was ever going to be successful, it was going to be an ultrasound-guided focus ultrasound system. I don't think that it was going to ever require full integration with MR.
And the last question, do you use contrast during the treatment, MRI treatment, like for ecography? We use Sonoview for the treatment for the treatment of prostatic cancer. For endometriosis, rectal endometriosis, it was not interesting to use Sonoview, but for prostatic cancer, it seemed to be really interesting. Do you use contrast when you treat with MRI?
So in the United States, no, you can't give contrast and then sonicate it again because of the concern that the chelation between the gadolinium and the chelator is temperature sensitive. Outside the United States, I'm aware that people sometimes will give a little contrast, and if there's residual, they will treat again and try to target that area. What we have done is we have developed, for prostate cancer specifically, we've developed a diffusion-weighted imaging-based approach that tells us which portion of this tumor or which portion of this prostate has been adequately treated. So we have a non-contrast method that we can do during the course of the treatment that correlates very well with the ultimate non-perfused volume.
Any questions? So thank you very much, and I really hope to come in a few weeks to visit your department.
Okay. Thanks again, everyone. Appreciate it.